office, as most of you know, and now you guys do too. But you're going to get to see me without a mask, which students haven't seen me without a mask for over 2 years now. How about that? So I'm going to put this over here. My voice will be much better. Probably I look better with the mask. Most people do, actually. Most people look great with the mask. Take the mask off, it's disappointment sometimes. So anyway, I'll try not to disappoint, but anyway, here I am. Are we rolling? Okay.
Camera, action.
So, welcome. You know what you're getting into? Ah, maybe you do, maybe you don't. Okay. So we're going to have a very great, intense, and 2 weeks. By the time you get to the end of it, you're not going to want to leave. But by the end of today, you're going to go, what have I gotten into? I thought I could do this stuff. And then you find out, okay, there's a lot more to it than I thought. So the learning experience you're going to have here is going to emphasize a lot more than you've ever had emphasized before. What it is that we really, what is good dentistry? You ever really think about that? You'd think everybody would have, everybody that's in dentistry practicing or what have you, you'd think, and especially those of you who work as dental assistants. How many of you work as dental assistants right now? It's a little bit lower than usual, but usually, typically about half my class is working currently as dental assistants. And so you see a lot of dentistry in this country and so forth, and you've done a fair amount overseas. But, you know, what is good dentistry? It's never changed. Good dentistry is the same as it was when I graduated. So I graduated, this is the 30th year since I graduated. This is the 30th year I've been teaching these courses. Okay? Just basically like this. Taught many different kinds of courses over the years, but the basic bench course on mannequins is something that I've taught for 30 years now. And, you know, during that period of time, you know, I've seen a lot of people from a lot of different places. And you'd think that everybody would have a pretty clear picture as to what good dentistry really is. But I'd like to kind of hear what you think. It hasn't really changed. The concept of good dentistry hasn't changed, but the quality of dentistry that's done out in the dental community has changed significantly. The quality of the education that you get in dental school has changed significantly. How you feel when you get out of dental school, the confidence that you have when you get out of dental school and go into practice has changed significantly. All that has changed in 30 years. There's a reason for it. We can trace a lot of this back to the events that happened in the late 80s, the events in dentistry that happened in the late 80s, new developments and so forth. And we'll be tracking a lot of what these developments have done to and for the practice of dentistry as we go through this course. We'll be working on a lot of different kinds of restorations and thinking about why they're done the way that they are and under what circumstances would they be done. But then we have to always come back to, okay, we know what should be done, and we're going to try to make sure we really get a sense of that, but also we have to face the reality of most of the time, dentistry these days is not done well. The dentistry itself is not done well, and the care that the dentist takes of the patient is not good. It's not the way it should be. So my goal for you is, yes, to get you through an exam to get you into a school. That's just goal number one. That may be the only goal you can think of right now. But my real goal for you is that when you get out of dental school, you will be confident. If you go to dental school thinking that if you just do what they tell you to do, you know, there's a curriculum, there's a program, and there's steps that you have to do to go through. If you just think that, okay, I'm going to go through and do everything they tell me to do, when you finish dental school, you will not be confident to practice dentistry. You will not be competent to graduate dentistry. The vast majority of dental students these days are not confident to practice dentistry. That wasn't the case 30 years ago. As I referred to earlier, 30 years ago, the vast majority of new dental graduates were quite confident and quite competent about being able to practice dentistry the moment they walked out the door. You know, I graduated with 100 other students. And when all of us finished, you know, the only people that didn't go directly into practice were the ones that were going into specialties. But everybody else, we just walked right into practice, you know, and the practitioners, the dental practices in the area were eager to hire us. They knew we were fresh, we knew what we were doing, we had a lot of experience, and we were cheap. But, you know, they're not going to inflict somebody that doesn't know what they're doing on their patients. You know, I got hired to basically run a practice when the owner of the practice wasn't there. So he was starting another practice some other place. So, you know, I was in charge of everything on the day that he wasn't there. That just isn't going to happen these days. So that's changed a lot. And we need to sort of sort out how that's changed and what you might do about it. Now, I have written on this. Maybe you've seen my writing on this subject before. There's a website that I put together called web-dds.org. I'll tell you more about it later, so you don't need to write it down or anything like that, but web-dds.org, there's a section for dental students. Main heading for dental students, and it talks about, you know, how you can get what you need out of dental school these days. So first of all, we need to kind of address, well, what do you need out of dental school? Okay? We need to figure out what it is that we really want to get out of dental school so that we have a sense of how we can get that and then be confident when we graduate and then be ready to practice and do good dentistry, which we still haven't defined, but we will in a minute. So as we go through dental school, you know, how are you going to, you know, what do you want to accomplish in dental school? You want to get a piece of paper that says DDS on it? Is that your goal? Well, you got to have it, right? You got to have that piece of paper. I mean, you're paying, what, $400,000 for a piece of paper? Is that all you're getting? Is a piece of paper for $400,000? Okay, you can probably find somebody that'll forge one for, you know, half that. But, you know, what you really want to get out of dental school, of course, is confidence. How are you going to get that? How are you going to feel that you've done enough dentistry in dental school so that when you graduate, you're ready to work on your own? You know, how much dentistry do you have to do? What's the area of dentistry that you feel the least experienced in right now? The broad area of dentistry. And it's an area that's important in this country because it's the way most practices make most of their money doing a particular thing that you might feel and probably feel least experienced and least familiar with. What would that be?
Restorations. Restorations.
Well, you've probably done a lot of restorations, direct restorations. Okay, an amalgam composite you're probably pretty familiar with. By the end of the day, you might feel less familiar with, but we'll build that back up again. RPDs? Okay. I'm a little bit surprised that you don't have as much experience with RPDs because that's a very cost-effective way to replace teeth.
We did CDs, but very
okay.
RPDs.
Okay. Well, RPDs are very cool. Yeah. But you've got to have the teeth that are left have to be able to support the prosthesis for sure. Okay.
I think field of periodontics.
Periodontics, okay, so yeah, that's a field that's not emphasized as much overseas, should be. but it doesn't tend to be, but that doesn't make you a whole lot of money unless you're a periodontist. If you're a periodontist placing implants, you can make some pretty good money doing it, but that's still not the bread and butter money making for a general practice. What's the bread and butter making money for a general practice?
Root canals.
Not so much. Yeah, you can certainly make some good money doing root canals if you're experienced as a general practitioner and can do all your root canals, multi-root cases, curved roots and so forth, rotary filing and that kind of stuff. Then you can make decent money at it. Yeah, but unfortunately, you probably haven't run into this yet. Although some of you who are assisting might have run into a practice where the dentist wants to do a root canal and everything. I have had students that come to me and they say, yeah, the office where I'm working, you look at the x-rays of the patients and all the teeth have root canals. Every tooth that has a crown has a root canal. That's called overtreatment. So you can make a lot of money doing it if you overtreat your patient, but that's a troublemaking situation. But what's the area where most money is made in a U.S. practice? Huh?
Prosthodontics, crowns and roots.
Fixed prosthodontics, crown and bridge. That's where the money is. Okay? So how much experience do you have doing fixed prosthodontics? Probably not much. So most of you are BDS, right? The bachelor part of it as distinguished from the doctor part of it. The difference usually is crown and bridge. Okay? And so I've had, many of my students tell me that, they went to their teachers in whatever country they're from and said, can you teach me some crown and bridge? I'd like to know more about doing crowns and so forth. And the teacher would say no. Okay? And the reasoning is because they're afraid that if you graduate and you know how to do crowns, you'll stay in the community and set up your own practice and do crowns, and there aren't that many people that can afford crowns in that community, and they want to do them all in their practices. Have you ever got the sense of that before, from wherever you're from? Yeah, that's not at all unusual stuff. So, the nice thing is you're here now, and crown and bridge is still an expensive thing, but more people here can afford it, but it depends on the community that you're in. On my website, I also talk about the business of dentistry, and one of the issues there is, well, who do you want your patients to be? Where do you want to practice? What patient demographics do you want? Do you want really rich people? Or people that are just trying to put food on their table every day? Okay, that's a question that you should ask yourself, because of course I can't give you the answer to that. We have two communities right near here. There's Newport Beach, California. It's just a few miles that way. It's right on the water. All these people live on the water. These houses are, 10, 20, $25 million. They all have these things out in front where they can put their boats, their fancy boats and everything like that. Well, there's certain things that you're just not going to do for a patient in Newport Beach. Okay? They can afford whatever they want. But you go a few miles in another direction, we have Santa Ana, which is a few miles this way. And, that's a kind of community where they're struggling, It's harder to find it. And if you want one crown, it's $1,500. It's hard to find an extra $1,500. In fact, a survey was done some years ago, which I just loved, and I've quoted it. I've seen other people quote this survey many times. They asked a whole bunch of people, thousands of people around the country, if you needed $400 right now, if you had an emergency right now and had to have $400 right now, what would you do? And the answer was fascinating. Most people said, I'd borrow it from a friend. Okay? So the implication is their credit cards are maxed out and they're living paycheck to paycheck and they have no savings. So no emergency funds whatsoever. So borrow it from a friend. So what if they come into your office and they need to have the entire coronal part of the tooth built up again? Are you going to tell them that they need a crown for $1,500? If so, what's that going to do to their finances? Or are you going to tell them, okay, there's something else I can do for $500 that's going to take care of the situation? Okay? It depends on where your practice is, depends on the kind of people that you want to help. If you want to help people that are struggling, and who isn't these days, except for the city over there, then, do you have the skills to do something for somebody that's going to take care of their needs without breaking the bank? Okay, so when it comes to doing good dentistry, that's certainly part of it. Okay, so back to the school again. We're about to go to school and you're going to have an experience where you can actually graduate confident in your abilities to do crown and bridge. But you're going to have to do the work. Okay, and by work, I don't mean do what they tell you to do. If you just do what the school tells you to do, if you do what's in the curriculum, do what's on the schedule of classes and so forth, it's not going to happen. So in crown and bridge specifically, the only thing that's really going to help you get confident when you graduate is having done enough cases. That's it. If you've done enough crown and bridge in patients' mouths, and I don't mean on a typodont, I mean in patients' mouths, if you've done enough different indirect restorations in patients' mouths, then when you graduate, you're going to go, okay, I can do this. I've done enough different situations and different kinds of weird conditions with different kinds of people, and there's enough variety of the things that I've done so that whoever walks through the door of the practice, I can probably figure out how to help them out, how to do the job. So the question to you is, okay, so you're going to go to school for 2 years. How many different cases do you think you ought to be doing before you graduate? How many units of crown and bridge would you like to have done by the time you graduate from dental school? Give me a number.
500.
500?
More than 500. I'm expecting that.
Well, would 500 be a bad thing? I mean, that's the first time somebody said as many as 500, but that's great. I will say that when I was at Loma Linda, there was an international program there that still is. It's in a separate clinic, and they keep track of the international students and their progress in terms of how many units they've done, and I was amazed. I think by the time I rotated through that clinic for 1 month as a junior, as a third-year student. And I think at that point I'd probably done 50 crowns or something like that. And I looked on the wall to see what the students in the IDP program had been doing, and several of them had done more than 200 units of crown and bridge. And I went, wow, these guys are rocking. So, and the cool thing is that when you're in that program, you could do the prep, take the impression, and send out the lab work and have it done. I had to do all my own lab work in the undergraduate program, which was great. The more you learn about doing lab work, the more you realize, what it takes to do a prep that actually works. So part of the time when we go through this course, I'll be asking, okay, here's a prep, and this is something that there's something on this prep that doesn't work, and you'll have to figure out what it is that doesn't work and why it doesn't work and what the consequences are going to be. And I relate that to experiences I've had teaching students where they're in clinic and they're trying to seat a crown and it's not working. And it's all because of their prep, and it's real easy to fix if they understand what the issue is. So we'll make sure we understand the relationship between how prep is done and the practicality of finishing it up successfully for a patient. But 500 units, that's a lot of units. Okay, but hey, if you could do 500 units, that's great.
I'm not sure that's what I'm expecting to.
Well, 500 units is better than 100. That's better than 5. If I had to ask you, would you rather do 500 units at Crown and Bridge or 5? I think everybody would agree 500 would be great, right? Okay, so what's the minimum that you think you should be doing? What's a minimum that you'd really want to do that would make you think that, okay, now I really get it?
Realistically, I would say 20, 25.
Okay, 20 or 25?
At least a 50 maybe.
50? Okay,
About 100, 150.
about 100? Okay, so those are good numbers. So, step up your goals a little bit. But certainly, reality is an important thing. So what is the reality of the school that you want to go to? How many units of Crown and Bridge do they do typically at the school you want to go to? Does everybody have a school that they're most thinking about they want to go to, or you just say, I'll take anybody that wants me, I'm there? Okay? If they want me, I'm good. I love that school. If they want me. But at that school, it may be really, really hard to do enough units at Crown and Bridge, in which case that school will not serve you very well. So how do you determine if a particular school will actually make it feasible to do 50 or 100 units at Crown and Bridge? How would you find that out about a school? Could you call them on the phone and ask?
No.
And what would you ask?
And just contact the current student
Yeah.
who's studying there,
And what would you ask?
like what kind of patients are you doing, how many rounds of bridges, how many extraction are you guys doing?
How about make it real simple? How many have you done?
Yeah.
Okay, and
Basically, like the patient flow, the number of patients.
Yeah.
that's too complicated. There's too much math in that. You know,
Yeah.
patient flow, hours in the chair, you know, clinic time is available, you know, all these kinds of things are, have to put them in a big equation and come up with a number. But the bottom line is, you know, for a given student that's there now, how many units at Crown and Bridge do they do? And can they tell you if the graduating seniors, you know, who did the most and how many did they do? It doesn't matter who did the least. It doesn't matter what the average is. What matters is who did the most and how many did they do. So if you have a school where the student that did the most units at Crown and Bridge did 50 or 100, that's good, okay? Now, if only one student did that many and the average only did 20, it's still good. Because again, if one student did 100, you can too. All right? That's the attitude I want you to have, okay? If anybody did 50, if anybody did 100, you can too. That means that the clinic time, the chair time was available to them to do that. The difference is how many patients do they have, okay? And a lot of schools will like give you out one patient at a time. Say, would you like a patient today? I'll give you a patient. They need one filling. And you spend all your time diagnosing and treatment planning, going through all this stuff, and then you get to do one filling. How about you go out and find your own patients? And again, on my website, directly to the dental students, I'm suggesting this. Go out and find your own patients. When I was a student, you know how we had to find patients outside the school? Now, the only time we ever did this was getting ready for clinical board exams. These clinical board exams, they require that you find a patient that has an ideal kind of lesion, so you can do a preparation that's pretty straightforward, so you're likely to get a good grade and so forth. But there was something missing from the environment that you're in. There's, you know, when I was in dental school, when I was finishing dental school, and I was looking to get my board cases, there was not as much ability to find patients outside the school as there is now, because of one huge difference. And this is one of those differences that changed the world. Okay? We're seeing a lot of world-changing things in the last 6 years, haven't we? Okay? But if you go back to the mid-90s, what changed the world more than anything? What made the world a different place for you than it was for me back then? Why did I have to take a 3x5, you know what a 3x5 card is? 3 inches by 5 inches, it's a piece of paper, it's kind of stiff, you know? It's got little lines on it, you can write on it with a pen. Pen. You've heard of that, right? Writing, you know, script, okay? And I write a little sign that says, you know, free patient screening for dental school. And I take it over to Walmart and I put it on their bulletin board. Okay? That's where people went to get information, to get offers, to find out what's available. They went to a bulletin board somewhere. Okay? So what's changed since then?
Social media,
Technology.
the
Social
technology.
media.
Yeah, social media was several generations further on. The internet. Yeah, that changed. Boy, did that change a lot. So yeah, totally new environment for you guys. So, I mean, you know, Craigslist, the ultimate Walmart bulletin board. Okay, and all kinds of other of those kinds of apps that are out there these days. So yeah, you post a sign on, post a thing on Craigslist that says free dental screenings. You talk to the dean of the school, because you're proposing to have students, or prospective patients come to the school and get screened. You'd like the dean to appoint a junior level faculty member to supervise you and 5 friends to screen patients on Sunday afternoons. The dean will be very happy to do that. The school won't do it themselves because that would seem to be that the school's competing with the dentists in the area. But as a student doing it, that's perfectly reasonable, and students do it anyway to find their clinical board patients. So once a year, that's a routine. So let's do it all year round. Why not? And then you get patients coming in and you make an arrangement with the school that says, okay, if a patient comes in and they need, you know, 6 or 7 crowns, then you get the choice to keep that patient, or if there's a graduate prosthodontics department at the school, then if you think that the case is too complex for you, or with advice from one of your faculty mentors, if the case seems to be too complex for you, then you present that case to the graduate prosthodontics department with a little bow on top, and they're going to be so happy. Okay? And the dean will be so happy. And the patients will be so happy. And of course, you'll have the opportunity to work on more complex cases, which are, you know, the similar kind of complexity to what you get in a practice. So you might as well start in right away. You know, why do a patient that needs 1 filling when you can find a patient that needs 15? My very first patient in dental school needed 15 fillings. It was great. I had her come in every week. I did a filling every week, for week after week after week. So my chair was always full, you know, just with her. I treatment planned her, spent 5 hours doing the treatment planning and the diagnosis and some prophy and stuff like that, and then bang, 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 lots of fillings after that, lots of restorative dentistry. And then same thing with crowns. I had a patient that I did 24 crowns on. Can you imagine? 24 units of crown and bridge on one patient. That was great. So you can find, you might not be allowed to do a case that's that complex. I had to beg to do that case, and I had to take classes off campus. But there in the next town, there was a guy that was giving world-class courses in full mouth reconstruction. He gave me the courses for free. So, you know, it's if you have in mind that you want to get the most experience possible, then you can do it. You know, make the opportunities, and you know, this is a way that you can proceed to do that. And don't get fooled by the minimum graduating requirement at the school you're going to. Okay, it's probably 5. Most schools it's 5. I have heard recently of a school where it's actually more than that, and the students typically do a lot more than 5. But most commonly, the minimum graduating requirement is 5. If you do 5 crowns in a patient, or if you do 4 in a patient, maybe 1 on a typodont, they'll give you a DDS degree, okay? And that DDS degree is worth precisely a piece of paper. Until you've done a lot more dentistry than that, a lot more crowns than that, you're not going to be able to manage what comes through the door of that practice, so you're not going to get hired. But even though the graduating requirement's 5, it may be that you can do 50 at that school if they provide you the access to the clinic and if you go out and find your own patients. Okay? So, my goal for you is not just to get you through the exam to get into the school. My goal for you is also so that you'll have a more realistic perspective on what it is that you need to do to get the most out of that school. You're going to be spending $300,000 or $400,000. Don't you want to get the most for your money? If you spend $30 or $40 on Amazon, you read the reviews, right? So you get the most for your money. You know, how many times have you read the reviews and said, you know, you really want this $40 thing, whatever it is. It looks great and you love it, you really want it, you can't wait, and you're about ready to push the button. They say, wait a minute, I better check the reviews. And you check the reviews and they're saying, this piece is junk. No, nobody in their right mind would ever buy this, this kind of stuff. And then you don't do it. You may read the reviews. In this case, for dental schools, make your own reviews. Go out and do your own homework. But if anybody can do it at that school, you can do it too. But again, you have to have a very realistic perspective on what it is that you can possibly get out of school. And then, of course, that comes from, looking at what you need to get and looking what people have gotten before you. But again, at a particular school, maybe only one person has done a lot of dentistry, but that's what you need to find out. You could also call the school and ask, okay, after graduation, where do the students go? Wouldn't you like to know? Maybe they all go into private practice, like they did 30 years ago. Much more likely, most of them will go into either an AEGD or a GPR program, okay, because they don't feel as though they have enough clinical experience. So they get into a GPR program, for example, and they're doing a lot of dentistry, but not necessarily well, because it's not an educational program per se. It's more of a doing dentistry, hospital-based dentistry and stuff like that. And AEGD is supposed to be more of an educational program, advanced education in general practice, general dentistry. But how much education they actually give you, how much of a mentor, how invested that mentor is in working with you and helping you learn as much as you can, varies from program to program. But if you can learn it before you get out of dental school, you're so much better off. And then you get hired into a practice, and then you can learn more in that practice. But you're already at a good foundational level. Okay. So, wouldn't that be great to graduate, at that level? Understanding why we do dentistry the way that we do, understanding how to do dentistry the way that we do, and understanding really what is good dentistry. Good dentistry. What is that? Give me an idea. When I say good dentistry, what pops into your mind? How would we distinguish between good dentistry and bad dentistry?
When the patients are satisfied with the care.
That would be nice. Wouldn't that be nice if the patients knew enough where their satisfaction was accurate? I mean, most patients, how many patients love their dentist? A lot do. A lot really love their dentist. Some don't. Some hate their dentist. Some love them, and it's warranted. Some dentists are really, really good. Some dentists really take good care of their patients. They do good dentistry, and they take good care of their patients. They are empathetic towards their patients. But there are a lot of dentists that are loved by their patients that can't do any dentistry at all. They just can't do or won't do good dentistry. But the patients love them anyway. Why do patients love their dentist? Maybe he knows the name of their dog, knows the name of their kids, and they're impressed by that. Oh, he's taking the time to, how's Fido when you walk in? How's Fido? Is he doing all right? And this kind of stuff. That's the name of the dog. Okay, so and who knows what people respond to, but it's not necessarily responding to the quality of the dentistry that's being done. It may not be even responding to the way they're treated. A lot of patients come into practices and they're stressed. And they might be stressed with a really good reason. They might have a history of trauma in their life. And so a lot of things will cause a lot of undue stress. And most dentists have no idea what that's all about. They just assume that, okay, everybody's going to be able to tolerate whatever I do, whatever I have to do, they're going to be able to tolerate it. And that may not be true at all. And the patient might get in the chair and just freeze in panic. And, let the patient do what he wants, and then they're even more traumatized. And that affects the rest of their life. And the dentist feels, oh, I did a good job. So, yeah, it'd be nice if patients could really feel that their dentist was somebody that they admired and so forth. And to do good dentistry, you really have to take into consideration the whole patient. And I mean their nervous system as well as everything else. Their nervous system and their finances. Those are two areas that, you know, probably you haven't really thought about before. Most dentists don't. Okay, but the patient's happiness is not necessarily a good indicator. Unfortunately. It'd be nice if it were. I mean, you know, how many times do you have patients tell all their friends about this wonderful dentist who they just love, and then the patients show up at the dentist and he's doing root canals and everything. But he's convinced them that they need root canals and everything. And, you know, he's convinced every patient that they need root canals and everything, but he's very friendly. They love him. When I was teaching, teaching in dental school, I had a colleague that was extremely loved by his patients. He and I used the same dental lab, and the lab technician told me that he had to tell them not to send cases anymore because his impressions were so bad. Okay, well that sort of clued me in. I mean, I love the guy. He was a good friend of mine, and I had no clue that he just wasn't doing good, you know, adequate dentistry. But he was just friendly and helpful. He always, the students loved him because he would, you know, anything that needed approval, he would approve. You know, the teacher that I went to, my mentor, he would not approve anything until he worked your butt off, basically, until you got it just right. Then he'd approve it. But I really learned what doing it right was all about. Okay, so yeah, your patients love you. That's great. It's necessary but not sufficient. The patients have to love you, and you have to actually be doing good dentistry. Patients don't understand dentistry well enough to be able to distinguish between what the results should be and what the results really are. That's why I wrote that website that I told you about earlier, web-dds.org. I wrote that for patient education. There's a section about dental students, but I wrote it for patient education so that hopefully patients would understand dentistry more, so they'd be able to know the questions to ask when they go into an office. There's one question that dental patients just don't ask, which is the most important thing. In fact, if you had one thing that was important in terms of distinguishing good dentistry from bad dentistry, it would be this. Okay, so let's get back to that question again and take some more input. How would you define good dentistry in the clearest possible way?
Do right by the patient.
It's too vague. Right is a pretty vague term, isn't it?
That is with a non-malignant attitude, like do not harm patient.
Okay, we don't want to harm the patient. Yeah, so it's, you know, the Hippocratic Oath and so forth, and that's great. Do no harm. How many dentists out there do you think live up to that oath? I'll tell you how to tell. And this opened my eyes like this big a few years ago. I went around, I was working on a program to how to calibrate new faculty hired at dental schools. So I was doing videos of various things, and so I could play the video for a new faculty member and say, okay, so here's the situation. What would you tell the patient if you saw this? Okay? Sorry, what would you tell the student? If the student did this, what would you tell them? What should they do? And so forth. So anyway, I was putting that program together, and as part of that, I went around to several different dental labs and started videotaping the cases. Okay, I videotaped the impressions and the dyes, mostly. And it was really, as I said, eye-opening. I was so angry. I did about 50 cases. One huge lab and then a couple of smaller 1 or 2 person labs. I was so angry when I saw the dentistry that was being done. I could use other words, but I won't because this is being recorded. But just suffice it to say that I was really, really angry. So of those 50 cases, most of them could not be used, but they were. Dental labs do not reject cases, except in the most extraordinary circumstances. So it seems like the job of a dental lab technician these days is to try to make incompetent dentistry work. Now, who is it working for? It's working for the dentist. So if the dentist doesn't get a good impression and sends the impression to the lab will make a crown that seats. So the dentist gets his money, so he can pay the lab. But the crown seats, but if the dental technician didn't know where the margins were, then how are they supposed to know where to put the margin when they make the crown? They don't. So they guess where it is, and then they make it short. Because if they guess wrong, they don't want to have a crown that won't seat because it's hitting the margin. So they wax it short, they create the crown short, and so they know there's going to be a wide open margin. Could be 0.5 millimeter open. And they send they send the crown back to the dentist, and they don't hear from the dentist. Okay, and you know what that means? That means that they cemented it with a wide open margin. Okay, so everybody seems to benefit except the patient. Now, of course, the labs hate that. They know the difference between good dentistry and bad dentistry. They hate the fact that they have to be making crowns that they know won't work. But they hate especially the fact that they have to accept cases from people that are doing horrible dentistry. They're doing dentistry that, well, they are demonstrating. The dentist, when they send an impression like that to the lab, they're basically telling the lab, I don't care. I don't care about my patient. I don't care if this crown works for them or not. Okay, and so I'd like each of you, at some point, when you finish the course and go back home, you'll have a very profound sense of what crown preps should look like. When you get back home, we will have done a lot of crown preps. A lot of different types of crowns, a lot of different situations, all different quadrants and so forth, and you'll have a very refined sense of what works and what doesn't work. And then go to some labs and visit them, and you're going to go, I can't believe it. In fact, I still have about 50 or 60 impressions that I rejected from students when I was teaching in school. So I still have these rejected impressions, and I was looking through them and looking at the bubbles at the margins and things like that, and then I'm comparing that in my mind to the cases that I saw in the practicing dentists in the area. And the rejected student cases are much better. You know, you could actually use them and make a decent crown, but it's not a perfect impression. But it could be made to make a crown that served the patient very well. So that's great. But what a shock. What a contrast. You know, what a juxtaposition. So looking here. Bad student work, way better than typical dental practice work. Anyway. So I don't want to generalize too much, but go to some labs in your area, wherever you are, and take a look and see what they're actually doing. Okay, so maybe that gives you some ideas about what dentistry should look like. And so when you, again, address the question about what good dentistry is, okay, can you think of something else? No. Go talk to Meg or Tim. That's the point.
Following evidence-based dentistry and understanding patient needs.
That's all good.
Yeah.
It's not the bottom, it's not where the rubber meets the road. You know that expression, where the rubber meets the road?
Doing the job properly, efficiently, the work that is required, and not doing some unnecessary work that that is not required.
Okay, so you certainly don't want to be doing work that's unnecessary just to
Yeah.
defraud the patient, certainly.
That's true.
And when you do work, you want it to be done efficiently
Yeah.
so that it's more comfortable for the patient.
So that you are satisfied with your work.
Well, if you do it efficiently, you make more money. That's a good thing. I wouldn't begrudge a dentist for making more money, but as long as the work is adequate, serves the patient well, and it's done, and the patient feels comfortable. Still not where the rubber meets the road.
Like neither like undertreat the patient or overtreat, somewhere in between, like some practices.
That's fraud.
Yeah.
So, yeah, certainly we don't want to be doing that. But, what is it?
Having a good hand skills,
Huh?
having a good hand skills.
That's part of it.
A treatment that's aesthetic and functional, lasts long, and mimics the natural teeth.
Okay, so doing restorations that the patient's happy with, that serve their social needs, if it's cosmetic dentistry, absolutely. But still, you could do a wonderful case that's very beautiful cosmetically and the patient's extremely happy. That's bad.
The prognosis should be good.
Say more about prognosis.
If the treatment stays for the patient and lasts longer, and then,
It lasts a long time.
yeah, that's what the.
That's where the rubber meets the road. Okay? I mean, if you're doing something if you're doing cosmetic dentistry, maybe you're doing an $80,000 cosmetic dentistry case, and you do it badly. Cosmetically, it looks great, the patient's very happy, and then, a year later, their gingival condition is horrible. Now it's not good cosmetically because all their gingiva is red and inflamed and bleeding. Or it has open margins everywhere. At one point, I was living in a house that was divided up into different apartments, and one of the other apartments was occupied by a dental hygienist that worked for a very high-end cosmetic dentist in Newport Beach, California. Very high-end, advertising full pages, and very expensive glossy magazines and so forth. And, I always thought, well, okay, obviously she's making a lot of money, she must be a good cosmetic dentist. And the hygienist told me she had to quit finally because, when she looked at the work that was being done, it was so bad. It had such poor consequences in terms of the periodontal condition that she had to quit. Okay. So yeah, there's more to it than just how it looks and how it functions now. It's how it's going to function further down the road. How long will it last? That's the question that patients don't ask. How many times these days do you have a patient come in and say, okay, here are the different options, and then, the dentist don't even provide different options. It used to be, you can have an amalgam or composite. What's the difference? Well, this is white, and natural, and organic, and looks beautiful, and so forth, and this is ugly and poisonous. Okay, of course, I just committed malpractice if I said that to a patient, because it's a lie. But, if the patient said, well, how long is the composite going to last, and how long is the amalgam going to last? I'll make my decision based on that. Okay? You're doing a filling in an area where nobody's going to see it, except for my wife when I'm asleep at night snoring. And she doesn't care what it looks like. She doesn't care if it's silver or tooth colored. So nobody's going to see it. I'm not concerned about the aesthetics of it. How long is it going to last? That's kind of an interesting thing. And we've already decided now good dentistry is dentistry that lasts a long time. Well, how long should it last? Depends on the procedure that we're doing. So if you're doing a class 2 composite, okay, some of you are doing dental assisting right now, so you're working in an office, and so you might have a sense of that. But, maybe you have a sense of it from other places anyway. So what's the typical longevity of a class 2 composite?
5 years.
You agree?
Around 5 to 7, yeah.
5 to 7? It's always an odd number. It's the strangest thing. I've asked this question many, many times. Nobody says 4 to 6. It's always 5 to 7. I'm not sure why that is. Maybe it's because, counting starts with 1. I'm not sure. Anyway, other opinions? Have you seen something different from that in the practices that you've worked in?
See lasting less.
Less.
Yeah.
Yeah. You know, in Germany, they all last exactly 2 years. This is not a bell-shaped curve. 2 years, they're all replaced. Why is that? Because the government pays for it to be replaced after 2 years. They don't require that you show that they need to be replaced. They just say, okay, if they've been in there 2 years, we'll pay you to do it again, to replace it. So the government is basically sponsoring patient abuse in Germany. Okay? At least that was true 10 years ago when I had 2 students 1 year that were both from different parts of Germany, and they both told me exactly the same thing. So if it's still true, that's a sad thing. That's a sad state of affairs. But in this country, it may be the same thing. The dentist, does a filling, and it's been in there for 5 years, and the dentist says, okay, there's a little bit of a little yellow stain around the side of it. We need to replace it. And the patient says, okay, do I have to pay for, $400 again? And so, well, sure, it's been in there 4 years, or whatever. No, it's the even number. Okay, well, that's kind of typical. But is that good? That's a different question. How long should they last? How long should a class 2 composite last in the patient's mouth? Have we forgotten this? Is this so far from reality that people don't know anymore? How long a class 2 composite should last? Let's say 12 to 15 years. That's what I was taught. That's the way I was taught to do a class 2 composite, so that it would last 12 to 15 years. So that's a lot different from reality. So what does that mean? The reality is that every dentist that you can think of that has class 2 composites that don't last 12 to 15 years are doing failing dentistry. They are not passing. They're not passing the test of being a dentist, okay? If they were really honest, I mean, can you imagine a dentist that was this honest? I would go to this dentist. No, I wouldn't. But if the dentist were this honest, the patient would say, okay, how long would this class 2 composite last? And he said, well, it should last 12 to 15 years, but I'm going to do a really careless job of it, so it's probably going to only last about 3 years, and then I'm going to charge you to do it again. Okay? And actually, when I got out of dental school, so that was 1992, 30 years ago this year, 30 years ago almost this month, I was so naive. I thought at that point that all dentists were doing excellent dentistry. I just assumed that because that's the way we were trained. We were trained to do excellent dentistry. So I was really naive. So I got out of school, and the next week I'm working in a practice. I worked with this guy for 9 months. I don't know how I got through that 9 months. I worked with this guy for 9 months. And one of the things he showed me is that, I'm watching him working on a patient at some point, and he's doing a class 5 composite. He says, he's showing me how to do it, and he explained it later. He says, if you put the composite in and you let the saliva just sort of cover the whole thing, and you put the composite in, it'll stay in for a couple of weeks, and then it falls out. And then you tell the patient that they're really tricky to do, but if you're willing to do it again for free, but if it doesn't work, then you'll have to do a crown. And then one time, toward the end of my 9 months, he actually had a patient come by on my day, and he'd been treatment planned for 2 crowns on upper premolars, 2 PFMs on upper premolars. And I'm looking at the teeth, and I could not see anything wrong with them at all. They didn't even have occlusal wear. And I asked the patient, I said, what's wrong with the teeth? Why am I doing crowns on these teeth? And the patient says, well, Dr. So-and-so, tried to fill these little things out here, these little notches. They were non-carious, abstraction lesions, just the very early stages. He said, Dr. So-and-so tried to fill those, and he tried it a couple of times, and he did it for free the second time, and he said, if they're very tricky to do, if it doesn't, blah, 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 we're going to have to do crowns. I said, I'll tell you what, I'm going to do these class 5 fillings, I'll do them, they're not going to fail. They're going to stay in there forever. I didn't say that. So I did them, and I sent the patient home. The patient was very happy, you know. I think we were charging $700 for crowns back then, so he's $1,400 richer. He probably took his wife out to a great dinner that night, celebrating that I did these class 5s. And so guess what happened that night? We used to have these phones that there was a cradle, and you put a phone in, and it had this twisty cord. Remember those?
Yeah, right now.
You've seen them in movies, right?
Yeah.
Okay. Okay, so I got a phone call, and I picked it up like this, and I had to hold the phone this far from my head because he was screaming so much in my ear. It was crazy. So I had to tell him, look, fire me, I'm ready. I'd already built my practice. I was just about to quit anyway. So fire me, that's fine. I don't have any trouble with that at all, but I wasn't going to do crowns on those teeth. And I read that was 30 years ago, and I read his Yelp reviews last year. They're pretty good. And then I read some of the bad reviews, and I realized he's still doing the same stuff. It's just the other people don't know it. So, yeah, it's still a matter of, doing good dentistry. Your patient might not be aware that you're doing good dentistry, but you are. But they'll be more aware when you do a Class 2 composite. And their friend has a Class 2 composite done by another dentist, and your friend had to have it replaced in 3 years, and and then the 3 years after that, and 3 years after that, and then you've had the same Class 2 composite for 12 years, and your friend's saying, how come I have to keep it changing it all the time, and you haven't had to pay that again? My dentist does good dentistry. How long should a Class 2 amalgam last in the patient's mouth?
15 to 30, 15 years, more than
Same
that.
as composite?
No, more than
No,
that.
more than
No, composite's 12 to 15, should
20 years maybe.
20 to 30.
15 to 20.
Yeah. Like in some patients you see like amalgam fillings, right, like from the 80s and 90s and, yeah.
Yeah, that's a long time. In fact, when I was a first-year dental student, I was taking a class, and they presented this paper that was recently published. This paper was published in 92, no, published in 88, when I started dental school. 50 years before that, so back in 38. A bunch of dentists in Chicago had done thousands and thousands of Class 2 amalgams. There was no composite back then. And it's just like the grinding up with mercury thing, which I'm sure you've seen. And so they had done thousands of these restorations, and then in the late 80s, they recalled the patients after 50 years to see how many of those Class 2s were still there. Most of them were still there after 50 years. Of course, they were done well. They were done carefully by dentists that knew what they were doing. So 50 years later, they're still there. So basically, it's a lifetime restoration. For me, of course, it would be. For you, it might not be. 50 years? You got more than that, right? Yeah, maybe. So, yeah, I mean, I get amalgam restorations all the time. They only have to last, what, 20 years for me? But, I don't want to change them before I die, that's for sure. I don't want to spend any more money than I need to. Okay, so composites, well, a well-done composite, 12 to 15. A well-done amalgam, basically 50, 60. The average composite done by a dentist is going to be 5 years. The average amalgam done by a dentist that's done, typically, it's probably going to be 25 or 30 years. Okay, that's a huge difference. And of course, amalgam can be used for restoring the entire crown. So you can do that, put in some pins to restore the whole crown with amalgam, and the patient doesn't have to have a crown then. They don't have to have a gold crown or porcelain crown or whatever. So we have options that most dentists don't want to think about these days, because when 1988 came rolling along and we had a choice of what was acceptable to do on a patient between amalgam and composite, well, we had a choice for the first time, and it's really embarrassing to see what's happened to that choice. Because, doing a composite, composite material, the development of composite material for dentistry was one of the most huge developments in dentistry. The amalgam was a huge development. Composite and all the technology that comes from composite was a huge development. If it weren't for composite, there would be no CAD/CAM. Okay? Implants, huge development in dentistry. Okay? Lots of things that we are familiar with now, PFMs were a huge development in dentistry. So, there's all this stuff that we can do, that we have access to, and are we deciding what's the best for each particular patient? Are we deciding how to do it the best so it's going to serve the patient well for a long period of time? It's an open question. But amalgam versus composite, okay, so dentists in 1988 would do a class 2 composite and a class 2 amalgam, and they would charge more for the composite. Okay, so if it's $100 for the amalgam, it's $150 for the composite. Does that make sense? Why would you charge more for composite than for amalgam? This is history now. And insurance companies would pay the dentist more to do a composite than to do an amalgam. Why?
Is it like sort of marketing to?
Marketing is really important. We'll talk about some genius marketing things in dentistry as the week goes by.
Boards are restricting amalgam filling.
There's nothing that restricts amalgam. Okay. In fact, if you say that you shouldn't be doing an amalgam, there are certain countries that do for one reason or another, or that where the government pays the dentist less for doing an amalgam than composite. There are some things about mercury waste and so forth, which is minimal compared to the amount of mercury waste that was produced and put into the oceans, decades ago. It's like huge, and still is. Basically, how many of you like tuna? Nobody likes tuna? Yeah, why not? What's not to like about tuna? Swordfish? You like swordfish? Seafood?
I'm vegetarian.
You're vegetarian.
No, I'm.
I am vegetarian.
You're a vegetarian. Okay, I was a vegetarian for a few decades.
We are
But-
vegetarians since we born.
Yes. Yeah, well, I was a vegetarian since before you were born.
True.
So, yeah, if you like seafood, if you enjoy that, then, these days we watch how much seafood, especially the big fish like swordfish, how much you consume. But, if you're eating seafood, you're getting way more mercury than we get from our fillings. So, the reality of it is that. And I'll tell you a lot. Well, you can read on my website about amalgam and the study that I was involved with that studied it. It's never going to be a bigger study ever done on that subject. But why do we charge more for, what do we base our fees on? If we're going to charge the patient a certain amount of money for something, how do we decide how much money to charge them?
Cost.
Expertise and the cost of the material.
Cost for the materials?
Expertise.
That's part of it. And what else?
Expertise, like how.
Now, the expertise comes into how much we charge per hour. So like when you have a car mechanic, if you take your car to a garage, then there's going to charge a certain amount per hour based on the expense of their education or what have you. Okay? So it's very, very fair to charge people a certain amount per hour based on your education. Okay, so that's the rate at which we charge. There's some cost for the materials, but it's minimal. But what determines the overall charge, the overall fee?
Technique sensitive,
Huh?
technique sensitive.
How much popular the material is for a patient?
We don't charge for popularity.
I mean,
Now,
Aesthetic.
I would say ideally we wouldn't, because it makes no sense. It's abuse of the patient to charge for popularity. Oh, you really want this? You really want it? How much do you want it? You really want it that much? Then I'm going to charge you this much money. You don't want it too much? Then I won't charge you so much.
Maybe aesthetic.
No, we don't.
The demand of that.
See, yeah, you see, and this is the point. The rate at which we charge is dollars per hour. We have to multiply that by hour. It's the time that it takes. The car mechanic, if he's going to take all day working on your car, he's going to charge you a lot of money. If it's a 10-minute fix, it's just not going to charge you very, very much money. He's still charging you $100 an hour, but it's just not so many hours. That's how we charge. So, the original cost of a class 2 composite, 150 versus 100 for amalgam, is because it took half an hour longer. It took 50% more time to do it. And what's really amazing is most students these days think that it takes longer to do an amalgam than a composite. That's why the composite doesn't last more than 3 or 5 years. Because if you did it right, it takes way more time to do it than it takes for an amalgam. And we know something about how that is, but it's even gotten worse than that, because now the companies that make the materials are making materials that are designed for like putting in a lot of composite all at one time and curing it, and it doesn't shrink as much. I don't know what the difference is in terms of shrinkage. I don't know really what the difference is in terms of pain afterwards. We'll talk about shrinkage and pain for patients in a couple of days. I'll tell you about a specific patient of mine. But when you have a situation where the dentist says, okay, oh, I've got this bulk fill composite, I'll just use that. It's not supposed to be used for the whole thing. It's just for the core when there's a big missing part of the tooth. You fill that, and then you restore the rest of it with the material that's designed to be used for posterior restorations. Well, I have a lot of students that work in clinics where that's all they use, is they use the bulk fill for the whole thing. So, you know, instead of taking an hour to do an amalgam or an hour and a half to do the composite, they're taking 20 minutes and doing what's basically a temporary filling, and they're charging the patient as if they're doing a really well done, definitive Class 2 composite. That's another reason why these things just aren't lasting very long. And of course, they do the preps in such a way that there's no way they're trying to save time by cutting corners on the preps. So even if you try to do a well-done restoration, the prep won't allow the filling to last as long as it should. So, I'm painting a grim picture, aren't I? Okay, but that's dentistry that you're walking into. We'll talk later about gold crowns and gold restorations and advantages and disadvantages compared to PFMs and full ceramics, and all this kind of thing, and why dentists would want to do full ceramics, and you know what's the financial drive behind that. And again, I will say, I'll generalize, most dentistry these days is done for the benefit of the dentist. Okay? Now, of course, it's a problem. The temptations are there because when you graduate dental school, you're going to owe a lot of money. So how do you reconcile that debt service with what you have to earn? And if you're working for a practice where they're doing unethical dentistry, okay, it's going to be tempting, so tempting to sort of turn a blind eye to that. But at some point, you know, and hopefully as we work through here, we're going to talk about, you know, what makes dentistry work. How do you do dentistry so it really does serve the patient for the longest possible time? There are many restorations that if you do them, that's it. The patient is taken care of for the rest of their life. Okay, so why would we do something that's shorter than that? If we educate the patient that, okay, this won't last as long, but, you know, it looks better, maybe. You might be doing crowns on the anterior teeth, and, you know, there might be an approach that might look better and it might not last as long. We might be able to do something that still looks pretty good and, you know, that it's going to last a long time. So being honest with our patients, you know, being honest with ourselves at first, and realizing that, you know, the way dentistry is done, there are a lot of choices that need to be made now. We have more choices as dentists than we've ever had before. So we will be discussing this as we go through the course. We're going to be talking about amalgams and composites and gold crowns and PFMs and full ceramics, how the preps should be done so that they will serve the patient for a long period of time. And sometimes how the patients are typically done. You know, what's involved with making the crowns. Of course, you're competing, if you get your practice, wherever you get your practice, you're going to be competing with dentists that have CAD/CAM machines. This is really interesting. How would you compete against, like, let's say you have an office in one block of one town and there's a dentist down the street, he's got a CAD/CAM machine, he advertises one appointment crowns. Okay? That's the value of the CAD/CAM machine, is the marketing. That's the way it's always been. Now, if you have an office in Newport Beach, California, you know, to save the patient an extra trip, you know, that patient might be earning $1,000 or $2,000 an hour. So they really value their time. And you should value their time too. So do good dentistry efficiently. But if you do a CAD/CAM crown and you have an open margin, which I have had in my mouth, and it fails later on and it has to be replaced, or if you don't cement it well and it falls off and they have to come back to have it re-cemented, what's with that? One appointment crown. Yes, you cemented the crown in one appointment, the next week it falls off and you have to come back to have it re-cemented? What have you just saved them? What service have you performed for the patient? Or if it stays on and it falls off 5 years later and they have to come back in and have it remade? Okay, whereas if you had done a decent crown in the first place, that's how to save the patient time. Okay, so the guy down the street has a CAD/CAM machine and you don't. Okay, how would you market so that the patients would want to come to you instead of to this guy down the street? How would you do your advertising? What would you say that would entice the patients to come and get a crown from you? You know, if it's an anterior tooth ceramic crown, I mean, you know, it'd be nice to do a big case full of ceramic crowns or veneers or something like that. Those are nice cases. For the dentist, they're nice cases. And, you know, if you do them well, then you can sleep at night. And if they have that aesthetic function, if you're a good cosmetic dentist, the patients are going to be happy, and they're going to be happy for a long time if you did a good job. So that's great. So how would you get patients into your practice that would otherwise be tempted to go down to the CAD/CAM guy? How would you entice them? How would you make them think that the crown you're going to do is better?
And it's a long-lasting crown.
Quality of your work, like long lasting. It's basically like from the word of the patients, like patient advertising, like patients saying, like talking to other people about how good the quality
Okay,
of
some
work is.
testimonials. They don't know how good the quality is. They might say, oh, this
Yeah.
crown lasted me,
Yeah.
it's been in my mouth for 25 years or whatever. Testimonials are certainly a help. Of course, there's a lot of stuff on you know, the Yelp reviews and this kind of thing. But your advertising, your marketing, you know, marketing requires buzzwords, right? Buzzwords, so important. Walk into a supermarket and look at what you buy. There's this product and there's this product. And there's a couple of words that somebody wrote on this packaging that just brings you to it. Something about what that says that makes you want to buy them instead of this stuff over here. So, you know, if you're decent at marketing, you might be able to come up with a buzzword. You know, I said earlier that I was going to relate something to you that I'll later in the week I'll relate it to you right now. In dentistry, the buzzword, it's not really a buzzword. It was created as a buzzword, as a marketing strategy, a marketing ploy. A particular kind of crown was given a name, and that name implies something about the nature of that crown and the use of that crown and the benefits of that crown. Those implications are none of them true, but the name makes everybody think that they are true. And so that has built that crown to the point where it's highly popular, the most popular crown ever developed, because of the name that some marketing guy gave it. Now, this laboratory that started this, it's a huge lab. They make, probably these days, they make $1 billion. Can you imagine a dental lab that does $1 billion of business a year? Can you imagine that? So they can hire really good marketing people. So this marketing person came up with this name, Bruxer. Ever heard of that? Bruxzir. So the name implies that, well, it states that they're basically zirconia crowns, which is true, but they imply that they're good for people that brux, which is not true. Okay? They imply that it's not abrasive, which is not true. If it were not abrasive, their advertisements would say these crowns are less abrasive or not abrasive. Well, they don't say either one of those things, and you know they would if they were. So all they had to do is name it that. And, you know, it's $1 billion of business right there. Just a clever name. So that's a great example within dentistry, but there are examples everywhere. Again, walk down the supermarket, walk into an electronics store. I don't know where you walk into, but just look on Amazon, see the words that are used. You should be able to capitalize on that. How would you use the supermarket buzzword experience to benefit you when it comes to trying to get patients to come into your office to get a particular kind of crown? And again, the contrast is between you and the guy down the street that does the CAD-CAM crowns. So, do you know how CAD-CAM crowns are made? You know the process, what's involved, the blocks of porcelain and all this kind of stuff, or zirconia, whatever is done. So we'll talk more about the technique for making them as the course goes on. But how about the fact that your crowns are handcrafted by an artisan from the old country? And they might very well be. Find a lab technician he's got his own lab. He's an old guy that knows what he's doing because he's just an artist, okay? And he can create crowns that have such richness and depth, and most dentists won't do one central incisor because they can't match the other one, especially on somebody my age. It's really, really hard to do. But a good dentist with a good lab where they communicate well, you can do that. But most dentists don't take the time or effort to do that because they don't care to do something that's really, truly handcrafted and customized. But you could advertise it that way, and that would, this crown is not made by a robot. It's made by an artisan from the old country. Hey, I'm there. I'll take that any day of the week. So, yeah. Knowing a little bit more about the reality of dentistry and how we do it, we're going to relate a lot of what we do to actual patient situations. And we're going to be working in mannequins that are, again, simulating the patient environment as we treat patients. I'm not interested at all in teaching a course where you're using a handheld typodon. Okay, you're not learning dentistry. You might be learning the way the prep should be done, but not how to do it. You don't learn how to do a prep by holding the typodon in your hand. You learn how to do the prep by putting it in a mannequin and having 4 quadrants, each different. What we do in each quadrant is different. How we do it in each quadrant is different. The way we have to see certain things is the same. There's certain things that we have to see as we go through our work. Okay? For example, we're working next to the adjacent tooth. We're doing a class 2, we're working in the box. We're working next to the adjacent tooth. What do you want to see? Isn't this a cool, basic question? You're doing a box. You're working near the adjacent tooth. Okay? Before you actually turn on your burr and start cutting in that area, what is it that you actually need to see? What do you have to see when you're doing that part of the prep?
Not to break the adjacent tooth, like when you're making the box.
We have to see if we're hitting the adjacent tooth, for sure. What else do we have to see?
Clearance.
Clearance? Okay, so once we finish the box, we're going to evaluate the prep by looking at the clearance between the proximal margins and the adjacent tooth. But while we're doing it, and we have the burr turning fast and we're in the prep, we have to see if we're hitting the adjacent tooth. What else do we have to see? Which direction? Well, we don't get to see the depth gingerly while we're doing the prep. We do it, we finish the wall, and then we look and see how much clearance we have as a separate step. But we can see and must see how deep we are axially. So there's axial depth and there's gingival depth, and they're different, and we'll talk about the differences. But we have to see how close we are to the adjacent tooth. We have to see how deep we are axially. We also have to see if the burr is vertical or not. Okay, we can't be leaning the burr facially and damaging the facial wall, or lingually and damaging the lingual wall, while we're otherwise taking care to make sure we don't hit the adjacent tooth and we're deep enough axially. Okay, so this gets to be kind of interesting. So we want to make sure we're not hitting the adjacent tooth. How do we make sure we don't hit the adjacent tooth?
By leaving like a lip of enamel when we're...
At some point we have to cut that away.
Yeah.
At some point, we're going to be working with the burr right next to the adjacent tooth. And what I'm going to suggest to you is that as we do the prep, we will work right up against the adjacent tooth all the time, as much as we can, so that the prep's actually going to be much easier and faster if we do that. So yeah, the old textbooks say, leave a bunch of stuff and then break it away, whatever. But every prep that we do in this course, we're going to be working at some point very close to the adjacent tooth, and we have to learn this lesson really, really well. So how do we avoid hitting the adjacent tooth?
Use a
Legal
tender
bed.
wedge.
Right, tries.
Okay, there are some things that we could do that are crutches to like wedge the apart, put some metal between them, but that takes too long. We're never going to do it in a patient. We have to learn how to work right next to the adjacent tooth without hitting it.
Having more control.
Well, have a good finger rest so we're not shaking around like this. Don't drink 8 cups of coffee and then start doing a class 2 prep. But yeah, we got to have pretty stable hands. We got a good finger rest. But what's the most important thing? If you want to know if you're hitting the adjacent tooth,
Being able to see where the burr is. Exactly.
to see where the burr is relative to the adjacent tooth. So that sounds kind of like a stupid answer, doesn't it? If we want to make sure that we're not hitting the adjacent tooth, we have to see if we are. All right? That's kind of obvious, isn't it? It's way too obvious, but it's the truth. If you can see how close you are to the adjacent tooth, that's what you put between the burr and the adjacent tooth, is you put your eye or light or some space or whatever. But if you can see how close you are to the adjacent tooth, we can work right up against it and know that we're not hitting it. But looking that same direction, we can also see how deep we are axially. We might not see the walls facially and lingually, but we can see where the burr is relative to the adjacent tooth. We can see how deep the burr is axially, if we're looking in the right direction. So when it comes to doing preps, we've got to be looking in the right direction. That's a critically important thing, and most of you today will be making big mistakes because you're not. So I'm just alerting you to that. In fact, you can't do a class 2 and look down the axis. We can't look down the axis to do a class 2 because now the handpiece is blocking our view, isn't it? So students sometimes, they in the upper arch especially, they look in the mirror, they're looking down the axis. They can't see anything because the handpiece is blocking the view, so they come up with a clever solution. Change the burr. I really want to look down the axis, so I'm just going to hold the burr like this, and then they can't see what the other side of the burr is doing. They're leaning it right into the adjacent tooth. And they can't see it because they're looking this way. Half of you today are going to do exactly that. You're going to look down the axis, you're going to kill the adjacent tooth because you have no idea whether you're hitting it or not. You're going to kill it. Half of you are going to do that. And I'm going to tell you, and I'm going to show you, if you're looking this way, you could have seen that you're hitting the adjacent tooth, but the way you're looking, you couldn't see it. And I'll show that to you many times. You'll see on your monitors from my video camera, you'll see exactly what you should have seen and what you could have seen if you'd been looking in the right direction. Okay, so that's kind of important to keep in mind. But that's just part of how we do a prep. That's just part of what we're going to be learning in this course. In this course, we are going to be using a tripod. I usually use the term stool, a 3-legged stool. A tripod has 3 legs. So do you notice that light on that stand? Is it falling over? It seems pretty stable, doesn't it? What if it were only 2 legs? That would be a problem. 1 leg? That's a pretty bad problem. Okay, what am I talking about? Okay, the way we're going to learn dentistry in this course, and you're never going to learn this anyplace else, unfortunately. There are 3 things that we're going to be, 3 completely different areas that we're going to be working on. Very deliberately, very carefully, very thoroughly. One leg is, why we do the prep the way that we do. If we're filling it with, or restoring it with some material, there's enamel, there's dentin on the tooth, there's something wrong with the tooth, we're going to be doing a direct or an indirect restoration. All this information is taken in and we design the preparation in our head. Okay? We visualize in our head the preparation as it should be done on that tooth, and we understand the fundamental principles that determine why we do it that way. So the design of the preparation in each individual case, and it's different for every tooth in every patient's mouth, but how we decide to design that preparation based on everything we know about materials, all the restorative materials and the tooth materials themselves, informs us as to how the preparation should be done. So we know what the preparation needs to be so that it will last the longest lifetime. Okay? Now, the preparation should be done so that the restoration can last its expected lifetime. We're not going to be talking as much about restorations, but we have to be able to do a preparation that will allow a restoration to be done that will last its expected lifetime. So understanding all of that is one leg of the tripod. Okay? Second leg of the tripod is, well, how do we do it? Okay? You got to choose a burr, and you get a handpiece, and push your foot on the pedal, and get a good finger rest, and see what you need to see. And we're going to talk about how we break the prep up into steps. Every step that you do, there's something that you need to accomplish. There's a certain thing that you need to see while you're doing it. There's a direction you have to look while you're doing it so that you see those things. And there's something that you need to accomplish by that step. And if you finish that step completely and well, then you do the next step, and the next step's easier. And it's faster, and it goes better. And then you do that one completely, and the next step. So there's fundamental principles of the design of the prep and fundamental principles of how we actually do it. Okay? Once we've figured out how we want to do it and then we've done it, the third leg of the stool, third leg of the tripod, is how do we determine if we did a good job? We have to look at it. We might have a mistake. That mistake could shorten the lifetime of the restoration, in which case that preparation that we just did fails. So we'll be talking about how we design the preparation in terms of how it should be done, but after it is done, we have to look at it very deliberately and try to figure out, okay, was it done well? Is there a mistake there that's going to shorten the lifetime of the restoration? We're going to develop techniques for evaluating the preparation. And the most important technique is that you need to be able to look for every specific error that could possibly shorten the lifetime of the restoration. And you need to be doing it in a systematic, strategically impactful way. Now, as an example, I had a student almost 30 years ago that brought a class 2 amalgam prep to me and asked me to grade it. And I said, I'm happy to grade it if it were done a little bit better. But there's a huge problem, and so I'm not going to grade it because it's a problem that you should see. It's really obvious. If you see it at all, you'll know exactly what it is I'm talking about. Okay? It's a critical error, and it's really, really obvious, and you should be able to find it. So I gave her 5 minutes. I said, take it back to your bench, sit down, and come back in 5 minutes and tell me what you found. So she came back in 5 minutes and said, oh, I think the angle's a little bit off here. I said, no, this is way more obvious than that. You don't have to think about it. When you see it, you'll know it. Okay? And it's a failing error. It's going to shorten the lifetime of the restoration. So I said, okay, again, it's really obvious. If you're looking at all, you're going to see it. So she came back and I said, take 3 minutes. I knew she wasn't going to find it. So while she was gone for 3 minutes, I wrote out a list of 10 things for her to check. So I said, she came back in 3 minutes, still hadn't found it. I gave her the list of 10 things, and I said, okay, check these 10 things. That's all I said, check these 10 things. She went, one of them was gingival clearance. She had no gingival clearance. Her gingival margin was still in contact with the adjacent tooth, hard contact with the adjacent tooth. As we'll discuss a little bit later, that's a bad thing. So anyway, so she comes back, and I gave her that list. She went to check it. She came back in like a minute. She said, I don't have any gingival clearance. What that told me was that people don't see anything other than what they're looking for. She had no clue that she didn't have a general clearance until she looked to see if she had some. So ever since then, I have had my students, for every prep that we do, make a list of things to check. And for every prep that we do, as I describe how the prep should be done, I'm basically making a list for you, and you're going to make your own. We have a workbook that you're going to use to make your own list. I am going to give you the list that I did, 34 specific things to look for in a Class 2 amalgam preparation, to see if you can find something that fails. See, that's my job. My job is to find something about your prep that fails. Okay? My job is not to tell you, oh, that's very good, very nice, oh, you're doing great. Okay? That's not why you came here. You came here to learn how to do better. Well, then you have to learn how you're doing right now, which is probably not too good. Okay? But the main thing is you're not looking to see where the errors are. You're not looking in any kind of a systematic way to see, okay, this is an error that's going to shorten the lifetime of this restoration. Okay? If you don't look specifically for specific errors, one at a time, then you won't see errors. Your brain does not want you to feel bad. That's the brain's job. The brain's job is to make you feel good. So whatever situation comes along, your brain says, okay, how can we interpret this in a way that's going to make her or him feel better? So your brain, her brain probably saw there was no genital clearance, but didn't allow her to actually realize it because it didn't want her to feel bad. Her brain didn't want her to feel bad, because if she knew it was there, she'd go, oh, I have to go farther gingerly. I don't have a good prep. I did something wrong. Oh, I feel so bad. And I'm scared. I'm scared to have to go farther. I'm scared if I go farther, I'll mess it up. So I'm going to leave a failed preparation. Well, the brain's going to force you into that situation. So by making a list, we override that impulse of the brain to make you feel good at your demise. Okay? So you want to find things that are mistakes. So part of this course is to train you to find not just other people's mistakes, that's relatively easy, but to find your own mistakes, that's really hard, because again, the brain's in your way all the time. So that third leg of the tripod, really, really important. And we're going to every day be working on developing worksheets, what I call them, which are lists of things to check for on preps. And the more detailed you are, the better it's going to be. The more you work with it and change it and modify it based on the experience that we have together. When I show you an error that you didn't see and you go, oh, why didn't I see that? Then write down on your list, look for that. Okay? And then take that list and build it, and because you're creating a tool that you use to evaluate your own work. Because if you don't do that, just for practical purposes, when you're taking an exam, your next challenge is you're going to be taking an exam at some school, wouldn't you like to be able to hand in the prep and know that it's good? Wouldn't that be great? How does that feel when you think about it? Just think now. How does your body feel? What sensations do you feel in your body when you think about the fact that you could hand in a prep that you know is good? Does that give you a nice warm feeling? Now think about what happens if you hand in a prep and you don't know. And you have to cross your fingers and you have to hope you did a good job. How does that feel? Tightening up a little bit? Okay, the difference between those two situations is that you know how to evaluate your prep because you've worked on it, you've developed a tool. Okay? You'll see me illustrating how to evaluate preps constantly throughout the rest of this course, hundreds of times, for all kinds of different preps. Okay? When you make your list, when you get to the point where you can systematically evaluate a prep and know that you're not missing anything, then you can have that good feeling and hand in something that say, well, I hope the examiner knows what he's doing because this is a good prep. And if he's not very good at examining, then, if he fails me, it's his fault. Wouldn't that be nice? The other thing that we're going to be doing as homework in the evening, we're going to be working on your worksheets. The other thing that we're going to be doing as evening homework is working on visualization. most people that I work with are not very good at three-dimensional visualization. Isn't that strange? You're all dentists. We live in a microscopic world of three-dimensional structures. And if you're not good at three-dimensional visualization, then that's going to be kind of difficult, won't it? So the students that I have that do the best are the ones that are good at visualization or get good at it. Okay? Which is why we have a workbook that has some exercises in it, and those exercises, which I'll describe a little bit later, those exercises will allow you to find out if you're naturally good at it right now. And if you're not good at it right now, then the exercise does more than just inform you as to whether you are good at three-dimensional visualization, but it'll help you get better, because as you work on that exercise more and more and more, and then finally you go, oh, okay, now I see it. Okay? It's a matter of you have a three-dimensional object, and what does it look like from different directions? I'll be drawing pictures on the board. I'll be drawing what a Class 2 prep looks like from several different directions. And somehow you have to assemble that picture into a three-dimensional image in your head, which you can turn around and look at it in different directions and so forth. And every prep that we do, it's very three-dimensional. Okay? So the more of a true sense of those three dimensions that you have, the better off you're going to be, the better you're going to do on your preps and so forth. The more you're going to be able to evaluate your preps well and so forth. So these are things, these are skills that are critical to what we're learning how to do. So, as I think you have figured out, I have very high goals for you. Not just to do well in this course, but to get through an exam and get into a school, but get the most you can out of that school, graduate with confidence, and practice using the appropriate buzzwords so you get lots of patients, and treat them well in the most important respect. Of course, respect them in every way that you can, but respect them in a very important way is that what you do for that patient should last them a long time, should serve them a long time, should be good use of their money. If you go to a dental school and do 5 crowns and spend $400,000, to my mind, the school has not done a good job. They have not set up the conditions where you get the most use of your money. Okay? As I said, every dental school used to graduate all graduates confident in dentistry 30 years ago. It doesn't happen these days unless you make it happen. So again, circling back to the beginning, I'm trying to give you a picture as to what it is that you want to feel, what it is that you want to be, how it is that you want to work, and then be able to achieve that, knowing what you have to do to achieve that. And you're going to have to do more than what other people are asking you to do. You're going to have to step way beyond that. You're going to have to do a lot, okay? To get the most out of your $400,000, you're going to have to do a lot of work beyond and above what they're asking you to do. And then when you graduate, you're going to be great. And that's what we're looking for. And people do this all the time, but it takes a considerable amount of work. There's an education at that school that's waiting for you, okay? But they're not going to give it to you, okay? They're going to pay for it, but they won't give it to you, okay? You're literally going to have to take it, okay? You're going to have to be determined to get it. I paid for it, I want it, give it to me. Grab it and rip it out of their hands, whatever you have to do. I think I've given you a little bit of sense as to what it is you're going to have to do it. And you've taken the first step already. You've taken the first step already. And what is that first step? You came here today. That's the first step. So thank you for that. You have, again, renewed my confidence in the aspirations of dental students, and hopefully I will gain your confidence as to making sure that we're doing everything we can to get you to a point where you can take the best advantage of what your future opportunities are.